I'll just skip that part. You can follow me with the name Dhruv Baru _DB9 on the various platforms. And before I begin, I would it would be a good ritual to thank Dr. Kishan, and we remember his quote that we become what we believe. So a theory which I believe has got me till here, so definitely it will help you as well. And Dr. Akash, who has been a very good friend of mine and has been always there at important stages of my life. So I have been told that the group is dedicated to MBBS students, and cracking the PG is the most important thing at present, right? So let's study the MCQs before actually solving them. So how are the multiple choice questions like B? Look something like this, not very good to look at and more or less confusing. Or it may look pretty like this, but still it's confusing to choose one amongst the four. So let's start with something fun and then go to the serious part. So I'll be showing a video clip and there are two questions to it. And the first question I have already shown. What is the brand of the sunglasses the actor is wearing? So listen to the audio, see the video, and more importantly, enjoy it.
Pushpa and a flower and fire.
Dr. Kishan, was the audio audible for that video clip?
It was audible. True.
Okay. Okay. So now, what was the brand of the sunglasses which he was wearing? One of these. And the answer is this plant. It's a touch me not plant. And the answer is do not touch such type of questions in the exam. And these questions I would call as SP questions, and there will be at least 3 to 5 such questions which actually should not be attempted. And what is SP? They are the sadistic pleasure questions. So before knowing what to do, what not to do is equally important in an MCQ exam. Now let's come to the second point or the second question. What is the meaning of the word Pushpa according to the actor? So this looks like a simple one: flower, fire, flower or fire, and can be either of them. The clue is according to the actor. What is the meaning? So according to the actor, the meaning is fire, not flower, not either of them. So the journey of entrance student is also like Pushpa. You have to be like fire, but when you get something, you have to be modest like flower. Because from flowers to fire, both are needed for a ritual, and life is the ultimate ritual. So now let us begin. And I want all of your enthusiasm to be like this. So the first question, the golden time in trauma is 1 hour, 3 hours, 4.5 hours, or 6 hours. Now let's study this with the help of a story form, because if you study it in that form, that's when you remember it for a longer time. So suppose that 4 of you, the crazy 4 friends, are on a trip after your final seat allotment, and when you are traveling, you see a road traffic accident, and you get to know that the patients of that hospital accident are to be taken to the nearest hospital, and you decide, okay, let's start our residency. So one of you search where is the hospital, and the duration which comes on your Google map is 1 hour. So break the word guessing habit. When you come across anything new for the first time, don't guess, because what you guess for the first time stays for a longer time and more likely for that to commit a mistake. So now let's reach the answer of this MCQ by studying trauma's tri-model. So as the name suggests, tri-model means it has to have 3 phases: first, second, and third. So first will be immediately, that is within seconds to minutes. Second will be within hours, and third will be delayed. So the answer is golden hour is the first hour. And why is it called golden hour? Because 80% of deaths occur in the first hour after injury. Now, if we know that 80% of deaths are occurring in the first hour, which is the golden hour, then we should also know why, what is the cause, because prevention of those deaths is our goal. So these are the injuries which are preventable, and that will be our next question. These injuries which happens within minutes or seconds, patient is unlikely to reach hospital and is likely to succumb before he reaches hospital. So our target will be these injuries. And as I said, the next question will be cause of death. So blood loss constitutes the most important cause of death in trauma, and that too 36%. So the golden time in trauma is, now we know, no word guessing. Golden hour is the first hour because 80% deaths happen with that. Now, golden hour, preventable causes of death. So A, B, C, and there are 2 causes in each one which need to be prevented: airway obstruction and tracheobronchial injuries, breathing pneumo and tension pneumothorax, and circulation hemo, as well as cardiac tamponade. But the most common cause of death in early hours is, so remember, what you study has to have its application in MCQ, because it will have all the options which you can think of, and the distractors like early onset sepsis, because the cause of death in early hours. So this is what is MCQ solving. And now we know the cause of death is acute blood loss. The answer will be so you reach the center and one of your friends who got an orthopedic seat was busy seeing the X-ray. So the boss comes and tells, prioritize. And that's when we study our next topic, which is triage. So in this bus accident, whom will you prioritize and treat first? Airway obstruction in a child, teenage with shock, flail chest elderly, and young male with severe head injury. Now, the distractors in this MCQ is age of the various patients which they have given. Now, whom will you prioritize and treat first? So let's study the concept of triage. Triage means, in simple words, to sort out or to prioritize. So it has been divided into four categories. And how do we remember it? So I, red, and immediate. Immediate means if not intervened, the patient is likely to die within minutes. The example is shock. D will be for delayed, and the yellow color, and treatment can be delayed for minutes to hours. And the example will be pelvic fracture. M is minor, walking around, cuts, abrasions, and X is dead. That is morbibound is the word which is often comes in the MCQs. So what is the mnemonic? I ditched my X. And how do we remember the X or black color is morbibound? You have to remember the dress which they wear in the funeral outside India. Whenever there is a funeral, they wear black dress. So you have to remember like this, that black is although about to be die, but least priority. So now let's apply that knowledge and see whom will you prioritize. Now we studied that shock is the one which will be prioritized. There was no mention of airway obstruction, flail chest, head injury, severe word is a distractor for you. So remember, shock is the second priority in this MCQ and airway obstruction, because child is likely to die within few minutes. And that's when the priority will be to the airway obstruction. Important point, MCQ point as well as concept, age has nothing to do with triage. The answer is airway obstruction in a child. Triage system is used for burns, earthquakes, polytrauma, or floods. Now, triage is used for any event which has mass casualty. So all of this will have mass casualties, but remember polytrauma. How do we remember? Trauma and triage. So, triage stands for trauma, and that's how we remember that has to be given priority. Next question, which color of triage is given the highest priority? And now we know the mnemonic, I dished my X. So I, red color, is more important. And remember, during entrance time, you are more important than your X. And that's how you remember that red is given more priority. Before moving on to the next segment of MCQs, a small break and a thought to think about. If it's a priority, we'll find a way. If it isn't, we'll find an excuse. So you have enough priority for this upcoming year of your entrance examination. Now let's come to the CNS proper and deal with the MCQs which are integrated with CNS. So how do we study? From superficial to deep, that is starting from the skin, scalp, and then going up to the depths of the central nervous system. So first, all of the following are layers of scalp except skin, periosteum, galea, or dura. So let's unlayer the scalp. Now, scalp, as the word suggests, the mnemonic, which is very old, very common, but still its application has to be learned. So from outside, skin, connective tissue, aponeurosis, loose areolar tissue, and pericranium. But what I want you to focus is connective tissue is the dense connective tissue. That is the first thing. Another name for aponeurosis is galea, and it's also known as the helmet of the skull, and L is for loose areolar tissue. So these inside things are to be more important than just memorizing the word scalp. Now, vessels, arteries and veins. So first thing first, arteries. Arteries are densely attached in the dense connective tissue, and that's why I asked you to remember the dense connective tissue. Now, what is the significance? Just imagine this is the layer and artery is densely adherent. So whenever there is a laceration of the scalp and injury to the connective tissue layer, because arteries are very densely adherent, they do not or they cannot contract, and so they will keep on bleeding. And that's why patients of scalp injury can bleed to death. And that's the MCQ and also a clinical application. Now, another important vessel is veins. So remember, veins lie loose in the connective tissue, and hence they allow easy spread of infections. So veins lie loose in loose connective tissue, and arteries are adherent densely in dense connective tissue. We'll also see how this knowledge will be applicable in our MCQs. So all of the following are layers of scalp except skin, periosteum, galea, and dura. So now we know that these three are the layers and dura is not a layer of scalp. As I said, along with the mnemonic, you have to remember 1 point for each layer. So skin, you have to remember sebaceous cyst, connective tissue, dense, arteries is the source of bleeding, galea or the aponeurosis known as the helmet of the skull. And remember this point, it is most important layer of wound closure and continues anteriorly into the eyes. Loose areolar tissue has emissary veins, which allows the spread of infection. All these points have been MCQ points and have been asked in the questions in the past years. So now let's apply. Hemostasis in scalp is best achieved by direct pressure, catching and crushing the blood bleeders one by one with the help of hemostats, eversion of galea, and coagulation of bleeders. Now, there is a common myth among students that the longest option is always the or most often the correct answer. And this is a perfect example of that myth being actually a myth. What has been asked in the MCQ is best achieved by. So all of these are methods, but which is the best one? So direct pressure, okay, but how long will you apply? Coagulation of bleeders with the cautery, okay, looks a good option. Catching and crushing the bleeders one by one with the help of hemostats, practically not possible to hold each and every bleeder, and eversion of the galea. So now let's see. So this is the example of our scalp tissue with the help of the layers. So we see this tissue is our galea, and this tissue has the vessels which cannot contract and it's continuously bleeding. And we can see that needle has passed below it. So here comes another 2 MCQ points. Look at this image. First question, what is the angle of entry of needle into the skin? And it's a 90 degree, and that is also a MCQ point. Also, there is something called Jenkins rule, which is not associated with neurosurgery, but it has been a past AIMS question. So what does the Jenkins rules state? That for a continuous suture, the length of suture required will be 4 times the length of the wound. So suppose a 5 centimeter wound needs to be closed. So the length of suture which will be needed will be 5 into 4 equal to 20 centimeters. It's a past AIMS MCQ. Just briefly, let me explain how does this 4 times comes. So suppose that's a 1 centimeter wound, and we all know that the suture should pass 1 centimeter on either side of the wound. So 1 centimeter from here till here, then there is a break 1 centimeter from here to here, and then the wound will be closed. So 1 on each side here and 1 on each side here comes to 2 plus 2, and that's the 4. So no need to mug up. Remember this point, and it's a past MCQ. Now coming to our question. So galea suture has 2 benefits. I told it's a helmet of the scalp. So it is important for wound approximation and reducing the tension over the wound. But the second point helps in hemostasis. And that's where our MCQ answer lies. It's the eversion of the galea, which is the best hemostasis for scalp. Now let's unlayer the brain. So the layers of the brain are called meninges, and from outside to inside there are 3 layers. Remember, in CNS, in brain, in scalp, the toughest layer will be outside and the smoothest or the softest layer will be inside. So there are 3 matters, what we call, and matter means mother. So the toughest mother or the layer will be the outside, and it is known as dura matter. Arachnoid means spider web, and pia will be, I call it choco pie like. So it will be smooth like choco pie. But what is the MCQ point? Dura, arachnoid, and pia mater. So pachymeninges is another name for outside layers, dura mater and arachnoid. And this has been MCQ. Leptomeninges includes which of the two meninges? So the inner one, arachnoid and pia mater together forms the leptomeninges, and this has been the past MCQ. Now, seeing the photo, guess the topic. Yes, it's a Glasgow city in Scotland, and what we are going to study next is Glasgow Coma Scale with the help of 4 MCQ and important updates. So, a patient was brought to ER in a semi-conscious state. He makes incoherent sounds, localizes to pain, and opens his eyes to pressure. What will be his GCS score? Now, there will be definitely 1 to 2 questions about GCS in the entrance. And students often make mistake, and this is a simple MCQ. If you understand, it should not be made a mistake. So let's study GCS first. So what is this? Electronic voting machine, EVM. And that's where are the components of our GCS score, E, V, and M. Don't get confused by the complicated image. Step by step, we'll be going and learning GCS. So EVM, eye-opening, verbal response, and motor response. Second MCQ point, which is the most important prognosticating or predictor of head injury? So remember, motor is most important. M for M, motor is the most important point. Yes. Now coming to the important options in our MCQs. So the red ones have been the updates. Now, how do we remember? You need not remember the entire GCS score because you are not going to write a theory exam. So that's where acting smartly is more important rather than hard work in case of entrance exam. So E2 previously was response to pain, now which has been changed to response to pressure. So this often comes in the MCQ, pressure. So you have to remember P2. Now incorrigible sounds has been given the score of 2, which often comes in the MCQ. So you remember P2 and S2. Amongst motor, the most commonly asked is withdrawal, and second most commonly asked is localizing. So how do you remember? P2, S2, W4. 2 plus 2 is 4. And you can't remember the entire score. This is the must remember. And let's see how we can apply this in our MCQs. So localizes to pain. Fine. This will be score of 5. Opens his eyes to pressure. So this will be 2. So 5 plus 2 will be 7. And as I said, sounds. This will be given a score of 2. Hence, the answer comes to 9. Now, a 42 years old with RTA has been brought with a decreasing GCS and currently opens his eyes to pressure again. What we studied is intubated and withdraws his left arm and leg to pain while abnormal extension in the right arm. What will be his GCS score? Remember, intubation or tracheostomy will be given the score or the response ST, and that score will not be added to the final score. So withdraw will be 4 and response to pressure will be 2. So here the score will be 6. it will be ideally 6T. Yeah. Now this is an important update and a likely MCQ in the upcoming NEET. What is it? GCS-P, and P stands for pupil reactivity. So if it is unreactive to light, that is pupil is not responding to light. If both the pupils are not responding to light, the score is 2. If one pupil is not responding, the score is 1. The important catch is total GCS will be GCS score what we calculate minus the pupil reactivity score. So the take home point is if the pupils are not reactive to light, the score will be downside to the normal GCS. That means suppose if GCS is 10 and both the pupils are not reactive, so the score will be 2. So the final GCS will be 8. And why was this added? Because pupil reactivity has been associated with prognostication in case of traumatic brain injury. So remember, you have to subtract the score from our original GCS score. A very simple MCQ, and still there are 10% of students who will be making mistake in this MCQ. The minimum GCS score is 1, 2, 3, and 4. Just apply our logic of electronic voting machine. And what is the minimum score for each one of them? 1, 1, 1. So the sum will be 3 and the minimum GCS score will be 3. Now, depending on the GCS, there has been classification of the head injury from mild to severe. Remember, higher the GCS score, better the prognosis, good for the patient. Lower the GCS score, poor the prognosis, bad for the patient. But when do we call it is a good GCS score and when do we call it poor? So you have to remember two numbers. 14 to 15 is considered a very good GCS score and a mild head injury. And 3, that is our minimum score. And 3 to 8. 8 for intubation, because 8 is a score where it's an indication for endotracheal intubation. Both are MCQ points. Severe injury, 3 to 8 is the score. Once the 8 comes, you have to intubate the patient. And lowest score has the poor prognosis. So coming to our answer now, minimum score is 3. Now we all know it. GCS score in severe head injury. Now we know you have to see for 8. And the distractor here is 0 to 3. There is nothing called GCS score of 0. Now, an important image-based question. M3 versus M2. Decorticate versus decerebrate posturing. Mechanism of action which you need to remember is midbrain, red nucleus, and a rubrospinal tract. Remember, rubroflexes. So, rubrospinal tract is located in midbrain and it flexes. So, any injury at the midbrain level is associated with poor prognosis. And how do we know that? Because rubrospinal tract will be injured and the vestibulospinal tract takes over and leads to extension. So, decorticate posturing, M3, good prognosis, decerebrate, M2, poor prognosis. And how do we remember in exam? Position of the elbows. If elbows are flexed, it is a decorticate posturing, good prognosis. If elbows are straight, that we call it extension posturing or decerebrating. It's a GCS score of M2 and is associated with poor prognosis. Before continuing, let's pause. A simple thing can GCS go wrong. So remember, you cannot do great things, do small things in a great way. If you cannot learn very difficult topics, pick up small topics like GCS and make sure that you score in them. That's the way for entrance student. What do you think when you see an image like this? What I see is the entrance student at the end of his preparation, reading 19 subjects, standing amongst the bunch of theory which he has read. A picture is worth 1,000 words. And why do I say so? If you see something like this, you're more likely to remember rather than read something like this. That's why I say, let learning be with pictures rather than learning pictures separately. And how do we study? We'll see in the subsequent slides. After head injury, biconvex lenticular shaped hematoma in CT scan is characteristic of which of the following? So these heavy words of biconvex lenticular shaped hematoma, invariable tendency of the student is to try and mug up those questions. So options are EDH, SDH, intracerebral hematoma, and diffuse axonal injury. Another question. After 4 weeks of head trauma, an elderly patient presents with features of irritability and altered sensorium. Commonest cause will be again the same options. The catch in this MCQ is the age of the patient, which is elderly, and the duration, 4 weeks. Let's see how in a simplest way we can differentiate EDH versus SDH. On the left, we have epidural or extradural hematoma. On the right, we have subdural or SDH. For simplicity, let's break it into two. So epidural, what we see first is we remember first. So it is red, and red means it's a arterial bleed. That's the first point. Second, what we see is a skull fracture. And for you, practically 95 to 100% EDH will be associated with skull fracture. We told it's arterial bleed. So what is the source? That is our next MCQ point. Torn middle meningeal artery. Now, important confusing point among students is which one crosses midline, which one doesn't cross the midline. So see, EDH is limited by attachment of dura to suture lines, and it does not cross suture line. As you can see, here is the attachment of the dura to the sutures. So it is limited by sutures. Now let's see the other side. We see the color, it is blue. So it's a venous bleeding. What is the source? It's a tone bridging vein. And as we know, it's a venous, so it's a slowly expanding venous hematoma. Now we can see it is extending towards the convexity and not limited. It is reaching up to the midline. And this is not reaching up to the midline. So SDH is not limited by attachment of sutures. So now we see them together, EDH on the left, SDH on the right. Just see the image and see the colors and remember what you see. Don't try to mug it up. Now let's see how this actually looks on a CT scan. So again, same EDH on the left, SDH on the right. Again, let's split up into two. EDH separately. So EDH is also compared to a lemon or a Karnataka idli shape. So it is biconvex. And SDH has been compared to a banana. Convex on the outside, concave on the inside. So now we applied that the same thing on the CT scan, what we saw in our image, but still our MCQ point is not discussed. Lenticular. Lenticular means it's a lens shape. What is the lens shape? Biconvex. So lens, biconvex, lemon or idli is EDH. So now it's easy to solve the MCQs. After head injury, biconvex hematoma in CT is suggestive of extradural hematoma. And 4 weeks. Remember, venous slow bleeding. So, and in elderly. Now, why elderly patients are more prone for chronic subdural is because there is atrophy of the brain and the bridging veins are lying loose, so more likely to rupture and cause the bleed. So chronic subdural hematoma. SDH is caused by injury of cortical veins. All these have been past MCQs and have been asked previously. Now SDH, another MCQ point, whether it is acute, subacute or chronic. So let's see on the scan and then remember rather than mugging it up. If you see a bright image, it is acute and the duration is 1 week. So remember 1 week is acute. 1 to 3 weeks is subacute, which will be having mixture. This has not been asked in the MCQ. This has been asked in the MCQ. Chronic. So how do you remember? 3 weeks and C. So C is the third letter, and that's how you remember. Chronic subdural is 3 weeks or old. Also in the scan, there will be bilaterality. So in a MCQ, if you see a bilateral hemorrhage, you can blindly write as chronic subdural hematoma. Important MCQ point, when do we consider for surgery? 5 mm or more of midline shift is an indication of emergency surgical evacuation. So answer to our question, SDH is caused by injury of cortical veins. Now, another question. Next point. What is the treatment of chronic SDH? These are the burr holes, and chronic SDH is drained by draining the burr holes. This can be the MCQ. It has been asked in the past. What is the name of this device? So it's a perforator, it's a burr, and this is how you make holes in case of chronic subdural hematoma. And the name of this device is, remember, it's a Hudson's brace. Hudson's brace is the name of the entire device, and this has been asked previously. Another instrument question. These are the burr holes, but what is the name of this instrument which is holding the skin into its position? So that's a self-retaining mastoid retractor. So two image-based questions, mastoid retractor and Hudson's brace, and treatment of SDH is not craniotomy, it's burr hole, and that also has been asked previously. Now the final image question. After draining SDH, you put a drain. What drain you put? JP or the Jackson-Pratt drain. And this also has been asked previously as a image-based question. Identify the drain. So this is the drain end which goes into the brain, and this is the bulb or the bag which collects the fluid. Now, why do I insist so much on visualizing and then remembering rather than mugging up? You heard of this famous quote, eyes don't see what the mind doesn't know. You see it, you remember it, and you remember it for a longer period of time. So when it comes to 19 subjects, if you try and mug it up, it doesn't work like that. It has to be a image-based learning rather than learning images separately. So now let's move on to the next segment. What do you see when you see something like a cyclonic movement? I'll call it swirling. And a skeleton talking to the patient's own skeleton, that is talk and die. And what is the other name of this talk and die? It's a lucid interval. So let's study with the help of this question. middle meningeal artery is the vessel commonly injured, usually occurs several weeks after trivial injury. Lucid interval is classically but seen in 1/5 to 1/3 patients and may be associated with a Hutchinson pupil. So first thing first, what is lucid? Lucid means temporary recovery. So how do we learn lucid interval? A patient has a head injury, he becomes unconscious, becomes conscious for a brief period of time to again deteriorate and become unconscious. So that state when he is in the temporary recovery phase, that is the phase between the two unconsciousness, is known as lucid interval, and it is a classical of EDH. Although classical, it is seen only in 1/3 of cases. Now, students often get confused whether it can be seen in SDH or not. Yes, it can be seen, although only in 10 to 20% of patients. But yes, lucid interval can be seen in case of SDH as well. Now, we studied EDH is an arterial source. And what is the artery? Middle meningeal artery. So how do you remember? MMA. That is a middle meningeal artery. Another MCQ points, what division or what branch? So it's a anterior division or the frontal branch. So remember, anterior division, arterial bleed is the source of bleeding in extradural or EDH. Now, where is the site of this fracture, which is commonly asked point? Pterion. So what is pterion? Pterion is a H-shaped junction. And the another MCQ point is, which of the bones forms the pterion? So you can see according to the color, frontal bone, parietal bone, sphenoid bone, and temporal bone. So which is not a part of it? Occipital bone. But what they ask in MCQ, which part of sphenoid? So it's a greater wing of sphenoid. And how do I remember it? You think big, you get big. So remember, it has a bigger wing of sphenoid and not smaller or the lesser one. What do you see? We see biconvex lens-shaped hematoma and convexo-concave banana-shaped hematoma. But what is this hypodensity or the black thing within the hemorrhage? We'll study next. First, let's answer our question. So in EDH, all is true, but usually occurs after several weeks after trivial injury, which is often forgotten, is chronic subdural hematoma. Let me share a real lifetime case which we encountered 2 weeks before. A 23-year-old male patient suffered a RTA and was having GCS 15/15. And this was his initial scan on presentation. At 4 o'clock in the evening, when he was talking to his mother, suddenly he became unconscious. So we got a repeat scan and it was shocking. The hematoma, which was just a thin strip, expanded into a big hematoma limited by suture lines and a hypodensity within. What is this hypodensity? It's a swirl sign. And that is another MCQ point. That swirl sign is seen in, again, it is classic of EDH, but can be seen in SDH as well. So if you don't apply what you have learned, it is not amount to learning. We applied the same concept of lucid interval and swirl sign or hypodensity and were able to treat this patient with a timely intervention. As an entrance student, do you often wonder why MCQs have been used in such a important professional exams to select? But let me tell you, it is not to select, but to filter out. And there has been an article on it where why MCQs has been a suggested technique. So let's see why MCQs are so important. They are not to select, but to filter out, because when you want to evaluate more than 1 lakh population, you cannot select amongst them. You need to filter out. And that's where 3 categories of students come into play. The most important and where there will be a maximum number is most of them are threatened by MCQs. There is 20% of students who build concepts, who are very good in theory, but they remain in between ranks. And there is a class of students who might not be very good at theory, but they are very good to play with MCQs. And these are the students which actually do well in the entrance examination. Have you often heard students telling that I almost get confused between 2 options? Yes, everybody tells that. Me as an entrance student also told that I confused between 2 options. So I thought, let's have fun with this problem. See this image and tell me which of the following is Aishwarya Rai. So out of the 4 options, which of the looks like Aishwarya Rai? So easily you have ruled out this is not, this is not. Remember, the real MCQ actually starts when you have ruled out 2 options. And that's where you need to slow down. Remember the golden rule. In 95% of questions, 2 MCQ options will be actually bogus and will be distractors. And the real MCQ is actually between 2 options. So never say that you are confused between 2 options. And another important mistake which students do, when they rule out 2 options like this, which are actually distractors, they try to rush to the answer and go to the next MCQ. The moment you try to rush the answer, take it from me, there is 98 to 99% of chance that you are going to make a mistake. So what do you need to do? When there are 2 options, you actually need to slow down. Try this technique when there are only 2 options, and if you slow down, there is 70 to 80% chance that you are going to get this MCQ right. Because when you slow down, you think calmly. Think about this slide, think about this method, and try it out in your next exam. Let's take a small break and listen to this clipping.
मेरा नाम दलजीत सिंह है। जिंदगी जीने के 2 ही तरीके होते हैं, एक जो हो रहा है होने दो, बर्दाश्त करते जाओ, या फिर जिम्मेदारी उठाओ उसे बदलने की।
Let me translate. He said, there are only 2 ways to live a life. Either accept what it is, or take the responsibility to change it. And I call, there are only 2 ways to solve MCQ. First, know the facts and knowledge. And when you know them, when a question comes, utter the answer and then look at the options. Means You know the answer. You don't look at the options. You utter the answer and then actually select the answer from the options which is there. And second is concept application. That means you don't know the answer and you actually rule out one by one and reach the answer. These are the only two ways where you are sure shot to get the maximum MCQs right. Either know the facts and knowledge, think about the answer in your mind, and then look at the options. And second is you don't know what the answer is and you rule out. If you keep it simple, you're more likely to succeed. Now, let's come to the next topic. What comes to your mind when you see such an injury? That's how entrance life or entrance students should be. That whenever you see the daily things, you should try to correlate it with your MCQs. So, which of the following is true except? Another important mistake which many students make is they don't see this word except. So, we are talking about DAI, that is diffuse axonal injury. Let's look at the options. We don't know anything and let's apply our second rule and solve this MCQ. Caused by shearing force, predominant white matter hemorrhages in basal ganglia and corpus callosum, increased intracranial tension is seen in all cases and most common at the junction of gray and white matter. So you can see the brain actually moving inside the skull cavity from to and fro. And what does this cause? Causes shearing injury. And what is the injury mode? There is an acceleration and a rapid deceleration. And you can see this is the gray matter, this is the white matter, this is the junction, and there has been a shearing. Shearing means tearing of the axons. So remember, shearing is tearing and axonal shear is the injury. Where is it? We can see easily it is in the white matter. This single slide has 6 MCQ points, and take it from me, diffuse axonal injury has to be one of the questions in your upcoming NEET. So what do you see? What you see first, you remember first. So MRI. So MRI is the investigation of choice. Where do you see the hemorrhages? In the white matter. The white matter in the brain stem. And this is also the grading of diffuse axonal injury. Mild, moderate to severe. Where is it? White matter hemorrhage. Another MCQ point. Cerebral hemisphere, corpus callosum, and brain stem where? Pons. And here comes our next MCQ. Previous past MCQ question. What are durate hemorrhage? So durate hemorrhage is nothing but seen in severe grade of diffuse axonal injury in the brain stem, that too in the pons. And why is this important? Predicts the length of comatose and persistence of deficits. So caused by shearing force, yes. Predominantly white matter, yes. The junction of gray and white matter, yes. Increased intracranial tension is seen in all cases, need not be. So that's our answer. Durate hemorrhages are seen in, as I said, repeat Ames MCQ. It's in the brain. Retraction ball is seen in. This is category 1 question. If you know it, you know it. So what happens when the axons get toned? The ends of axons get retracted. And they form ball-like swellings. And what are these balls? Retraction balls. And it's a forensic findings, not an MRI finding. So it's a post-mortem finding. Where are the retraction balls seen? Sorry, that the answer is diffuse axonal injury and not tracheobronchial. Sorry for that. Now, neurosurgery is indicated in all. So we have studied EDH, we have studied SDH, depressed fracture we don't know, diffuse axonal injury we don't know. So this is our second way to solve MCQ. We'll try to rule it out. Remember, diffuse axonal injury. You cannot operate on anything which is diffuse, and especially in the brain stem. So the answer here will be depressed fracture. This is the difference between your theory and MCQ exam. It's a diffuse thinking versus focus thinking. Tactical and methodical is what will get you the MCQs correct. What comes to your mind when you see something like this? You get hit and there is a rebound injury. Concept of coup and counter coup. Remember, where you get hit first or a patient gets hit first, that is the site of coup. Coup means impact. And when there is a hit on the exact diagonal opposite side is a counter coup injury. So here the impact has been here and the counter coup injury has been on this side. Contusion versus concussion. Let's study with the help of this apple, which is fresh, and the apple, which is shrunken. So remember, contusion is like a focal injury which you get on your knee joint or your thumb, where you apply a band-aid. So it's a focal injury. And concussion is a diffuse. You see the apple is entirely shrunken. Can you apply band-aid over there? No. And which is more severe? This is just a focal injury. This is a diffuse injury. And what is the mechanism? Rotational acceleration without any much mechanical contact. So remember, contusion is a focal injury. Concussion is a diffuse injury. And let's sum up the traumatic brain injuries. Concussion, although diffuse, is the mildest form. And what is the severest form of the diffuse injury? Diffuse axonal injury, as the name suggests. That's why both had similar mechanism of injury in form of acceleration and deceleration. Contusion, remember the band-aid, and coup counter coup, where coup is the impact and counter coup is the diagonal opposite side. Let's take a brief break and think about this. In life, in your MCQs, it is the close observation of the things which is the secret. Remember, in MCQs, the answer is in front of you. If you have a close observation, and not only in MCQs, you need to develop close observation in each and every aspect of your life to succeed in your MCQ theory exam. What is this? If you remove the skull cap, what do you get? Skull base. Six MCQs and surely a very confusing topic for students. Let's see how we can make it easier. So skull base fracture, all of the following are features except it's a neat repeat question, raccoon eye, hemiparesis, CSF rhinotoria, and battle sign. Now remember, anterior, middle, and posterior. Three fossas or the skull base has been divided into three. So the first MCQ point is, which is the most common side. So anterior is the most common side. I'll give you a very important tip. Eyes and nose are associated with anterior cranial fossa and ears are associated with middle cranial fossa. If you just remember this, all the MCQs associated with skull base fractures or the basilar skull fractures will be very easy for you. And there are two signs which we need to remember in each of them. So let's see. First, a halo sign. So don't try to mug up. What is a halo? A dark center with a light surrounding. That is known as a halo. So blood is at the center and CSF forms a clear rim. That is known as a halo. Halo or a target. So that's a target sign, but it is non-specific. So next MCQ point. What is specific? Beta 2 transferrin is specific for CSF testing. So CSF coming out of ear, it is known as otorrhea. Blood within the tympanic membrane, hemotympanum, and post-auricular ecchymosis or hematoma, that is known as battle sign. Don't worry, each of this will be studied in the further slides and will be revised adequately. So what do you see? A raccoon and a girl dressed like that, just for you to remember. And this is how actually it looks. A raccoon and a patient with a raccoon sign. So raccoon eyes is nothing but periorbital ecchymosis, and it is a classic of skull base fracture. But where else you can see? So it can be seen in this condition, and that's another MCQ point. It will be an except MCQ. Now, the next option. Longitudinal fracture of the temporal bone is associated to have tympanic membrane perforation. And we saw in that image, CSF coming out of the ear, that will be CSF otorrhea. But what if the tympanic membrane is intact? The same CSF will find its way through nose. And that's what we call as paradoxical CSF rhinorrhea. So skull base fracture is associated with all of the following. Raccoon eyes, yes. CSF rhino or otorrhea, yes. And battle sign. Hemiparesis is a feature of brain stem injury or motor strip, but not skull base. Now CSF otorrhea is caused by, I told, otorrhea means ear, and where you get ear means it's a middle cranial fossa. So which amongst the following is a middle cranial fossa structure is what you have to do. So cribriform is a anterior cranial fossa, parietal bone is a distractor, useless. There is nothing called fracture of tympanic membrane. So this is also ruled out. So what is remaining? Fracture of petrous temporal bone. And let's study in detail. So petrous bone fractures are divided into two: longitudinal, which is parallel to the petrous apex, and transverse, which is crossing the petrous apex. This is how it is seen in the CT imaging. Longitudinal is parallel along the axis of petrous bone, and transverse is perpendicular. You need not get threatened by this complex looking table. You have to just remember what I have highlighted. So first MCQ point, which is more common? Longitudinal is more common, first point. Which causes more physical damage? Physical damage in form of tympanic membrane perforation, otorrhea, hemotympanum, it will be longitudinal. And which causes more neural damage? Transverse one. So facial nerve injury is more associated with transverse fracture. Another MCQ point. So CSF otorrhea is caused by fracture of petrous temporal bone. Base of skull fracture patient presents with involvement of petrous temporal bone. Which of the following important sign is seen? Now subconjunctival hematoma is eyes, rhinorrhea is nose, raccoon eyes is again eyes, and battle signs. So our trick, all this will be anterior cranial fossa, and we know temporal bone is middle cranial fossa. So the answer here will be, very sorry, it is battle sign and not raccoon eyes. I'm extremely sorry. All of the following are feature of anterior skull base fracture except. So ecchymosis periorbital eyes, rhinorrhea nose, halo sign we know it's a CSF rhinorrhea? So the answer will be mastoid, because mastoid is a part of ear and middle cranial fossa. Now, a patient presenting with normal sensorium and blood in the tympanic membrane. So, application of what we learned, hemotympanum. And it's a feature of basilar fracture. It's another name for skull base fracture. Management of CSF rhinorrhea. Also past AIMS question. So in CSF rhinorrhea, remember 70% of leak will stop in 7 days. So the treatment is masterly inactivity. And the management will be just antibiotics and observation. There is something wrong with the this thing. The answer is antibiotics and observation. So now let's revise skull base fracture. Eyes rhinorrhea, feature of anterior cranial fossa fracture. Otorrhea, Battle sign and hemotympanum, middle cranial fossa fracture. Let's take a pause. Our character is not defined by the battles we win or lose, but the battles we dare to fight. And life lessons are learned in the middle of the battlefield. And let's revise our MCQ point. Battle sign is a feature of middle fossa fracture. So now let's sum up. EDH, limited by suture lines, extradural bleed, subdural over the convexity, not limited by suture lines, and the remaining two, SAH as well as ICH. So SAH. MCQ points. What is the most common cause of SAH? And it is trauma. Because the second most common cause is cerebral aneurysm. So SAH, most common cause is trauma, and second is aneurysm. Triple H therapy. Where do we use it? SAH caused by aneurysm. Bleed is where we use triple H therapy. What is that? Remember, you give more fluids. So if you give more fluids, there will be hemodilution. If you give more fluid, there is hypertension. So triple H stands for hypervolemia, hypertension, and hemodilution. Don't mug up, just remember SAH is treated with fluids, that is hypervolemia, and you will automatically get the second two options of the MCQ. When you have learned something and an image comes across, all you have to try is try to correlate and remember what is it. So pterion. Question is, which are the 4 bones forming pterion? There is an injury at pterion, fracture. What is the vessel? MMA. And now the hemorrhage which was left out. So that's the hypertensive bleed. Most common cause of bleed in gangliocapsular region is hypertension, and the most common site is putamen. Again an MCQ point. Now how do we remember? HP. So now whenever next time you go to refuel your car or your two-wheeler and you see a HP, you have to correlate. H is for hypertension. So where it will cause bleed? Putamen. So that's how you remember your MCQs. the earliest manifestation of raised intracranial pressure following head injury is earliest ipsilateral pupillary dilatation, contralateral pupillary dilatation, altered mental status, and hemiparesis. So remember this diagram, but what you need to remember is headache in a conscious patient and changes in LOC, loss of consciousness, in a altered sensorium patient. And a Cushing's triad, a raise in BP, a fall in pulse rate, and irregular respiration. Again, and except MCQ. An important point and important concept which you have to learn is, if a patient of head injury develops hypotension, they should always develop hypertension and bradycardia. So if a patient of head injury develops hypotension, rule out two things: spinal injury, associated spinal injury and shock, and second will be a bleed. So bleed, but at some other site. And let's learn the important concept what we have been taught in trauma. Bleeding sites in trauma, 1 on the floor and 4 more. But what is that? One of this on the floor is external bleed, means the one which you can see, like this, a patient who is bleeding from this side. So this is 1 on the floor. And how do we remember the 4 more? So remember this, 4 more shots. And what are this? Chest, abdomen, pelvis, long bones. This is all for fun and learning sake, so don't take it otherwise. 1 on the floor, 4 more, and you can remember this image, and whichever you want, you can give. What happens when we are preparing for entrance? We often get lost. We often get lost thinking about results. So just give it your best, because more often than not, you actually get more than what you want to. So the earliest manifestation will be altered mental status. And let's revise the Cushing's triad: hypertension, bradycardia, and bradypnea or altered respiration. And let's study and correlate the next thing: shock, which will have opposite features. Hypotension, here it will be hypertension. Here it will be bradycardia, it will be tachycardia, and respirations. So this is how you correlate one thing with another and read and remember. Indications of CT brain in trauma. There has been one question which keeps on coming on the CT: where is it not indicated? So what is this? A rope. And I'll be telling what is a rope point, what I have labeled in my MCQ exam preparation. So remember, it's a rope point, that is rule of passing entrance examination point for all patients from mild to severe injury, that is GCS less than 13 need CT. All pediatric patients, that is less than 16 years, need CT. All age 65 years or above need CT. And vomiting. This has been a MCQ point, and I accept MCQ in AIMS. Vomiting more than 2 episodes. And the option is in those question is 1 episode of vomiting does not need a CT. Remember this point. 1 MCQ, 1 episode of vomiting does not require a CT evaluation. Lastly, coming to the end of our trauma section, indications for elevating depressed fracture in skull. So all open fractures and with neurological deficits need surgery. That is rule number 1. What are the indications in child and adult? So this is the MCQ point. 8 to 10 mm depression is an indication. More than 5 mm below the inner table or the thickness of the skull, and the ones nearing the frontal sinus because of the risk of dural injury as well as future pneumatocele. So, and in children, ping pong fractures are an indication, and the last but not the least, cosmetic. So, how do I remember? Nobody around should be depressed, nor you, nor the skull fractures. So 5 points in case of skull fractures: open and comminuted, you need to elevate them. Associated with dural injury, yes. Contaminated, yes. What is the thickness? 8 to 10 mm or the thickness of the skull nearing frontal sinus, ping pong, and last but not the least, cosmetic. So elevate. Failures are a part of life. If you don't fail, you don't learn. If you don't learn, you will never change. Now let's study Monroe-Kelly doctrine. Let's just directly go to the MCQ points of it. So what you need to remember is normal ICP is 5 to 15 millimeter of mercury. The normal cerebral blood flow is 55. So what Monroe-Kelly doctrine says that 3 structures in the brain are always in a harmony. What are they? Brain tissue, CSF, and blood. Now, how do we apply this? We'll see in the next slide. So what are the causes of raised ICP? There are n number of causes, but just remember FAB4, trauma, tumor, TNT, VI, vascular, and infection. So the raised ICP says, you can't bring me down. And what do we ask the brain to do? Drink a hypertonic solution. And that's where the methods to control ICP. So first, head elevation to 30 degrees, it facilitates venous return. Again, an MCQ point. Mannitol 20% is what the drink that brain was drinking. What you have to watch is serum osmolarity should not exceed 320 millimoles. Intubation and ventilation, ICP monitoring, and sedation and paralysis. All these are proven methods to bring the ICP down. And what is highly contraindicated? Steroids are contraindicated in trauma, hypotonic fluids, hyperventilation, and hyperglycemia. And this has been a repeat MCQ point. Which of the following is actually dangerous for a brain injury, which is high amount of glucose levels? And what if everything of this is not able to bring it down? You do a DECRA. And again, an MCQ point. What should be the length or minimum length of a DECRA? It should be 12 centimeters. What is DECRA? Decompressive craniectomy. I'll be coming to that in the next 1 or 2 slides later. An MCQ point in central exams. Which of this is a level 1 evidence? So remember, there is no positive level 1 evidence. There is only one negative level 1 evidence, that is steroids have no role in traumatic brain injury, and rest whatever we are applying clinically is all just level 2. And another point, which is level 3, hypothermia has no role. So remember, 1 and 3 negative, and rest all falls under level 2. So this is what DECRA is, and a very routinely done neurosurgery. So this is the flap for DECRA, and what I meant 12 was this to this minimum has to be 12 centimeter for sufficient decompression. And this is how it looks after we remove the bone. This is where you all want to reach? A road with full of lights, but the road to a dream branch is actually like this. For that, you have to tie the rope or cling onto the rope. And rope points means rules of passing entrance. And to sum up the trauma section of our neurosurgery or CNS based MCQs, take these rules of passing entrance points and a definite MCQ options as well as direct MCQs. Indications of surgery in trauma. Any point which mentions midline shift of more than 5 mm is an indication. 10 mm thickness of SDH, 15 mm thickness of EDH or 30 cc volume and 20 cc volume of contusions. These all are rope points which you need to either remember or cling on, whatever it is, but they are your MCQ points. So Monroe Kelly simplified. Normally, 3 components what we saw: blood, brain, and CSF. So what happens when there is a lesion which is trying to get into this compact brain? So brain parenchyma cannot change. So what are the 2 things which can change is CSF volume and the blood volume. So compensated, there will be a decrease in the volume of arterial blood reaching and increased venous drainage. Once it becomes uncompensated or raised ICP, there is further compromise. And there comes a point where there is no more compensation, and that's where the brain herniate downs. And that's where our next MCQ. 4 types of herniations which you need to remember. Just I'll simplify in the form of MCQ points. First, what is the structure? It's FARCs. So what is the structure? Tent. So these are the fixed points from where the brain actually herniates or moves out of its position. What is this which herniates? Uncus. Uncus is the temporal lobe. Uncal herniation is associated with ipsilateral dilatation with contralateral weakness. And why there is dilatation? Because uncal herniation will cause third nerve palsy, and third nerve is a parasympathetic nerve which causes constriction, and if it is paralyzed, what happens? It leads to dilatation, and there is contralateral weakness because there is ipsilateral cerebral peduncle which is getting compressed. But what if there is such a big mass and it is causing compression of opposite cerebral peduncle? So it will cause same side weakness, and that is what is known as Kernohan's notch, ipsilateral pupil dilatation with ipsilateral weakness. Before jumping on to the next sections of neurosurgery, let me share a small story. What is PG entrance? 19 subjects. Each subject has a MD or MS super specialty, 3 years each. So 19 subjects and 3 years each. It takes 27 years to master those 19 subjects. And you tell us, master them in 1 year. For guys, it will be like a shocking reaction. For girls, it will be something like this. And some of them will be like, it is injustice. And this will be the reaction. What is the solution of it? Why do we require 1 year preparation? It is to study all, not master all. Study and compile all. Organize and discipline. And what is the deciding factor is the minimalistic notes, which you can look at a glance and brush and rush through. So that is where the 1 year comes into picture. What are the things which can actually let you down even after preparing so well? Complacency. This guy, I have worked here for 20 years and never made a mistake. He's not aware that the alarm is ringing. And what I call near misses or the unforced errors. Minimum the unforced errors, maximum your chances to be in those top 1000 rank. And what I mean by unforced errors, a simple question like this. The chromosome pattern of Klinefelter syndrome, we all know it is 47. But when the options are like this, don't tell that I have solved that more than 20 times. It is that moment which is important. How many of you tell that I read it very nicely, but I was not able to revise it? So what happens? You eat too much. There is so much around for entrance students that you take it, you put on weight, and then you think that you can do it, but you end up being like this. So read only what you can revise. You have to study 19 subjects, not master 19 subjects. And what do I mean?
Anybody else? Yes.
Sir, machines are any combination of bodies so connected that their relative motions are constrained, by which means force and motion may be transmitted and modified as a screw in its nut or a lever arranged to turn about a fulcrum or a pulley about its pivot, etc. Especially in construction more or less complex, consisting of a combination of moving parts or simple mechanical elements as wheels, levers, cams, etc.
Right. This now.
Thank you. Thank you.
सर मैंने भी तो वही बताया सर आसान भाषा में आपको अगर सिंपल भाषा
So what do we learn? Entrance is not about mugging up.